Okay, let's get this presentation started. So just a brief disclaimer, this information is provided in the presentation. It was current as the time of the presentation. However, to be most up to date, please visit the Quality Payment Program's website at qpp.cms.gov for the most current information. So briefly looking at our agenda for today, we'll talk about the transition to value-based healthcare, how to choose the right outcome measures, what are the benefits of patient-reported outcome measures, what are the different types of data collection methods, and what is on the horizon for patient-reported outcome measurements. And as we mentioned previously, please enter your questions into the text box and we'll do our best to answer them. Please enter them throughout and we'll answer the questions at the end of the presentation. So starting off with the transition to value-based healthcare, let's begin by looking at how this fee-for-service system has transitioned to a value-based healthcare system. The idea behind value-based care is simple. Rather than payment being tendered for each service, healthcare providers will be reimbursed based on patient outcomes. In the traditional fee-for-service system, each service item is unbundled and paid for separately. Alternatively, in the value-based healthcare system, reimbursement is now tied to the provider meeting certain outcomes and performance measurements. Looking at this June 2016 McKesson report, what this is showing is the increased movement towards the value-based reimbursement models and how payers and providers see themselves in this transition. So nearly twice as many payers, 45%, said they were ahead of the industry in transition to a business based on value, compared with only 24% in 2014. Providers were also optimistic about value-based care, with 31% reporting that they were ahead of their fellow providers, compared to 22% in 2014. The report also asked payers and providers to locate themselves on a continuum between a pure fee-for-service volume-based system or a pure value-based care system. Payers responded that 58% of their business had shifted to value-based care, up from 48% in 2014.
Right, and I think that when you look at this transition to value-based care report, that's really the important takeaway, is that outcomes are here to stay, but then it also tells us that the transition from volume to value is progressing. Right, this is a report that looks at a timeline from 2014. And we can see that both payers and providers feel that this is progressing forward, not regressing backwards. So.
The seismic shift caused by the transition from a fee-for-service structure to an outcomes-based approach is really challenging our healthcare system to reassess how value is quantified. Healthcare consumers are becoming more engaged and proactive as decision makers, and this is changing the healthcare delivery mode. This movement towards outcome-based care continues to disrupt old practices and workflows, and it will be important to identify, quantify, and evangelize the emerging benefits of value-based reimbursement systems. At the heart of value-based healthcare is the collection of outcomes data using validatable instruments. This information fuels a feedback loop that assists providers by incorporating patient-reported outcomes.
Yeah, I really like this this visual because it implies continuous improvement, right? There's a collection of data and analysis, and then some type of change in behavior based off of what the data is saying. I would also note that the application of this type of continuous improvement not only applies to patient-reported outcomes in the treatment of patients, but also to some of the other objectives that the outcomes data can be used for, such as like quality reporting, right? So collecting outcomes data for quality reporting, and then based off of those results, sort of recalibrating for the purpose of continuous improvement.
Choosing the right outcome measures. The goal of a value-based care is the delivery of outcome-oriented, patient-centered care. Foundational to this approach is the role of validatable outcome measurement instruments that capture and quantify a patient's healthcare experience. And this includes their self-reported health status over time. So choosing the right outcome measures really becomes key. However, choosing the right outcome measures can be a daunting task. For example, let's look at the number of measures that are available just for the shoulder.
And so, it's when we were looking at choosing the correct outcomes questionnaire, it's really just more than selecting one from this list. And just choosing one from all these options is difficult enough, but there's some other things to also consider when making your selection. Things like, what scores do each of these outcomes questionnaires produce? Are they free? Is there licensing required to use these questionnaires? Who else is using it? How big of a data set exists for those questionnaires? And then even simple things like how many questions does it ask? This is all patient-reported data, keep in mind. So how many questions are we presenting to the patient? How much time does that take? So all important things to consider.
So as you can see, there's a lot to understand about outcome measures. However, you don't need to be an expert. There is an increasing move towards providing standards on how to choose these measures. Much of this work has been accomplished by Michael Porter at Harvard, and this has become a significant driver in this movement. So looking at how standardizing patient outcome measures really accomplishes is it allows a comparison that will accelerate care improvement, and it also allows providers to collect and share data on outcomes more efficiently. So in 2015, the American Academy of Orthopaedic Surgeons created the Quality Outcomes Data Work Group, and they convened to investigate and evaluate data collection tools known as patient-reported outcome measurements, or PROMs, in addition to other charges. The QOD work group considered a world of PROMs and tools for collecting of orthopedic quality data and using specific criteria to evaluate each PROM. So let's take a look at these criteria that they used. The first is an open access to PROM, and this is something we mentioned previously. There's no cost for using the instrument itself. Patient-reported outcomes only, meaning there's no surgeon data entered here at all. The information is coming directly from the patient as the source. There are multiple entry platforms, which include digital, paper, or web-based, that really give the patient flexibility in providing this information. And there are approximately 20 questions or less, therefore reducing the burden of answering these questions on patients. They're clinically meaningful. There's one generic quality of life patient-reported outcome measure that can be used across all specialties, and there's no more than 3 joint or disease-specific patient-reported outcomes. There's also a CAT version available, which is preferable, and this is computer adaptive testing, which really allows you to reduce the amount of questions that you use while still keeping that standardization criteria in place.
Yeah, I would just, I don't want to go too deep on to the CAT technology, but one thing I would just say, like Valen just mentioned, computer adaptive testing, or CAT, that refers to certain methods of reducing the number of questions that a patient has to answer in filling out a patient-reported outcome while still providing an accurate assessment. And one other thing I would say is that, or I guess one thing to consider is that, aligning your choice of patient-reported outcome measures with some of the objectives that you're looking to achieve with the outcomes form. So, for example, quality reporting to MIPS. And if you think about the measures, the quality measures that you'll report, how do your outcomes forms and your selection of those outcome forms align with the quality measures that you want to submit? And so I would just sort of throw that out there as something to consider, is the alignment of the quality outcome measures with your patient-reported outcomes forms.
So in February of 2016, the AAOS Board of Directors approved these recommendations of the QOD work group, and this also included a recommended list of patient-reported outcome measures. So let's take a look at this list. So as you can see, there's that general quality of life that we mentioned before that can be used across all specialties, and then there are also joint-specific criteria and questionnaires that you can use.
Yeah, one other thing to note here about each, the list of forms under each subspecialty, is that there are shortened versions of these forms available. So like if we look at the knee, for example, there's the COOS listed there, and then just under that there's the COOS Junior. Same thing with the hip, and so for hand and wrist, there's the dash, and then there's also the quick dash. So something else that's important to note, for most of these validated forms, there are shortened versions available.
So AAOS has greatly assisted us in the selection of PROMs, and OBERD is offering PROMs that align with the AAOS recommendations. So let's take a look again at the difference between looking at this exhaustive list and what AAOS has helped us to accomplish.
And something I would just say sort of in summary is that, really the problem we're presenting here is like selecting the correct validated outcomes, patient-reported outcomes measure. And so AAOS has done all of the work for us already, right? So they've made recommendations for forms that have a minimal number of questions that produce meaningful data. They're popular. There's a lot of people who use them. And again, they're not overburdening the patient.
So let's shift a little on the benefits of patient-reported outcome measurements. Okay, so looking at this recovery timeline, what we have here are patient-reported outcome measurements that follows a patient over a continuum of their treatment. And this is done through a series of checkpoints. And this really enables a dialogue over time between the patient and the provider. And it helps to monitor and detect changes over time. Outcomes forms are distributed at each time point seen here and that help in the assessment of a patient's progress.
Yeah, so now that we've made the selection of the which patient-reported outcomes measure to use, that's really the next question, right? Is how can we use them? And so I think the most basic application is sort of the assessment or assessing or administering these surveys to the patient across a timeline, which is what you're seeing on the screen. So a pre-surgical assessment and then several post-operative assessments. And again, the value of that is you're collecting data, you can sort of trend and track the patient's recovery. So that's, again, the most basic application, I would say.
So let's look at the benefits to the patient. And what this does is enables a patient to communicate their function or feeling with their provider. It provides a patient perspective on the treatment benefits by giving them the opportunity to relay to their provider how the treatment has been working for them. It also provides an engagement of patients in the assessment of their own care through this open dialogue and through the point of providing this feedback information to their clinician on a regular basis. And this really, in summary, enhances the patient-physician collaboration. The benefits for the healthcare provider is that this allows them to identify predictors that may lead to poor outcomes and correct these to lead to better outcomes in the future. It also allows them to detect poor performing prosthesis and surgical techniques so that these can be improved upon. It also reduces the number of complications over time by having that series of checkpoints to check in periodically. It assists providers in medical and surgical decision making. It also is contributing to the reduction of readmissions.
Yeah, and I want to elaborate just a little bit on that last bullet point, the contribute to the reduction of readmissions. I think that by collecting patient-reported outcomes, it not just collecting it, but then presenting it to patients and physicians, I think it creates an opportunity to improve care, potentially lowering cost. Kind of an example of what I mean by that is, if you've got, say, if we just take like a total joints patient, like someone has a total knee replacement, and you've been asking patient-reported outcomes questionnaires, and you have pain and function for that patient, as a standard, as part of the standard care path for that patient, you may already have scheduled 3 months follow-ups, 6-month follow-up. But for that 6-month follow-up, you may look and be able to say, okay, well, we've got the patient's pain and function. Pain is low, function is high. We don't need to have the 6-month follow-up appointment. You could call the patient, you could cancel that appointment, you're reducing costs, and you can schedule a separate new patient appointment in that slot instead.
Evidence-based healthcare is driven by data. And what the goal here is to gather, leverage big data in a way that you can distill it down to an individual patient. And what this does is really make it meaningful to their unique healthcare scenario. For example, let's take a look at allowing a patient to now see patients like me. And what we mean by that is really using big data in a usable conversation between the patient and the physician, using all this information that has been gathered that can help an individual patient be placed in a cohort of patients that are like them with similar demographics, similar lifestyle habits, and they can really see at a certain time period picked for an elective surgery what their outcome would be based on patients that were similar to themselves. And what this does is it really empowers patients and physicians to make the best decisions.
Right, and we've kind of been talking about patient-reported outcomes data sort of within the context of the patient and only the patient, sort of that single assessment. But when you sort of add that patient's data in the context of a much larger data set, I think that you're adding an additional layer of meaning there. Just like Dr. Prasad said, you've got the patient data, but you've got that sort of benchmarked with a massive database of data from patients that have the exact same patient profile, so that you know how to treat the patient, or you have a better idea of what the patient can expect with a particular treatment.
Shifting a little to how patient-reported outcomes can fall into MIPS compliance, let's take a look at the quality performance requirements for MIPS of 2017. And this comprises 60% of your overall composite performance score. And the minimum requirements is to report at least 6 quality measures, including 1 outcome measures. And this is a mix of process and outcomes, outcomes being either clinical, patient satisfaction, patient experience, or a patient quality of life. And what this really does is give you the opportunity to not even limit yourself to just 1 outcome measure, but you can actually choose more outcome measures. And I'll have Paul elaborate a little bit more on this.
Yeah, I had mentioned before sort of the concept of aligning the patient-reported outcomes forms with the quality measures that you select to report for MIPS. And I want to reiterate that here. Selecting quality measures for MIPS is almost the same type of problem as selecting the patient-reported outcomes form that you want to use. It all starts with the measure. And so I think that it's important to sort of grasp the concept of aligning those two things. If you're collecting pain, function, quality of life, patient satisfaction, then I think it would make sense to also choose quality measures for MIPS that are focused on pain, function, quality of life, and so on. So I want to make sure that we're aligning those two things, quality measures for MIPS, patient-reported outcomes measures.
Monitoring MIPS quality performance throughout the year really gives you a chance to gather, analyze, and recalibrate this information. And what we mean by this is through conducting regular performance audits at various checkpoints throughout the year really gives you the opportunity to identify optimization opportunities. If you see lower scores in a certain area, it gives you a chance to correct what is going wrong and increase those scores so that by the end of the year, you're really optimizing that composite performance score.
And this links back to one of the first images that continuous improvement image that we showed at the beginning of the presentation. This is essentially the same thing. I mean, if you're, as you collect data, patient-reported outcomes data, and if that data that you're collecting from the patient you're using to report for MIPS, that's going to be sort of a continuous stream of data into your system, and then based off of what that data is telling you, you can sort of recalibrate as needed to make sure that what you're submitting for MIPS is going to get you the highest score possible.
So let's take a look at the different types of data collection methods. How can I accomplish this?
Yeah, so your options really can be categorized into sort of 2 groups. You can like paper and then electronic. And so what you're seeing now is an example, obviously, of a paper form. So this is the IKDC, and certainly a valid option, but you'll see that there are some disadvantages, right? So it's cluttered. There's a lot going on. Questions. There's double-digit questions on a single page. And even if we just look at this one example here, you'll see just in this one question, there's actually 9 total questions, again, all jammed into one tiny space. So another option outside of paper, there are some electronic options available, and there's going to be a number of advantages to collecting data electronically. And on the screen, I'll point out, a paper option on the right, and then there's an electronic option on the left. But like small things, right? There's only one question on the screen at a time. you're able to do things with the electronic options that you can't do with paper. Color code the answer responses, auto navigation, right? The formatting of the answer responses is such that they're easy to select, right? They're easy to read because they're large. And then in addition to the outcomes options, you can see that the electronic distribution of forms is going to extend beyond that. So we can even do things like mobility, which is what you're seeing on the screen now, right?
So on the horizon for patient-reported outcomes, so as we discussed earlier, patient-reported outcomes measurements allows us to look at a patient outcome over a continuum of care. And we have already seen how technology is enabling this process of efficient data collection. But let's take a look to the future a little bit. So as we can see here, there are time periods where we have pointed out here 90 days and 364 days of missed data opportunities. And there are emerging mobile technologies that promise to enable this ambient data collection. So the value is not limited to static checkpoints at this stage, but now you can have data being collected in a real-time format.
Yeah, like what Dr. Prasad is saying, you know, we have these sort of isolated time points where we can collect data from the patient, but there's a lot of sort of unsupervised time, right? Time where we're not collecting data from the patients, and that could be arguably, you know, be fairly meaningful. And so I think that the way that we see data collection, outcomes data collection moving in the future is that we're going to have more streamlined options so that, you know, we're moving away from these isolated time points and rather we're getting sort of a continuous feed of data from the patient.
So what we're kind of predicting here is this smart auditing of ambient data from mobile and wearable technologies that, as Paul was saying, will really help us develop a robust collection of data over a period of time, as opposed to having static checkpoints.
Yeah, you know, one other thing I would say is I think you could make the argument that the time, like the 90 days immediately following surgery, of course, depending on the type of surgery, is more important, or the data is more actionable at that time than it is, say, like 4 years after a surgery. And so I think when we're talking about like streamlined data collection, it's important to note because, you know, you could, if we're talking about reduction of costs and reducing readmissions, I mean, you could have streamlined data feed from that patient immediately following the surgery, so that if you see things like a pain increase or infection or something, you can immediately engage with that patient, make the appropriate adjustment so that the patient doesn't have to be readmitted for any reason.
And this concludes our presentation. Thank you so much for joining us today.